and also, a country of birth, it is a very emotional experience. So I thank you. I also would like to compliment AORA on this fantastic initiative, and I bring greetings to you from Europe, the European Society of Regional Anesthesia, a sister organization. We have been around more than 30 years, and we would be very pleased to collaborate with you and be of any assistance. During my term as Secretary General, I had the pleasure of helping many Indian colleagues and also from other so-called low-resource countries to help with reducing registration fees drastically. And I would urge you to come to our ESRA meetings. And although I'm not the Secretary General anymore, I think we can help in some way in case you're interested. My topic is the use of regional techniques to improve outcome. And we had an excellent lecture by the surgeon who showed in graphic detail some pictures, and they are like miracles. And I think he's done already the job I was supposed to do. He was telling how good regional techniques are, and he would not have been able to perform those miracles without regional techniques. The picture says more than 1,000 words, and you saw those impressive pictures. However, it's not quite that simple. I think in science, we know that it's not enough with those pictures. We also know that we are not privileged to have those kind of surgeons. Those are more exceptions rather than the rule. And also, scientifically speaking, who is to say that you could not have had the same kind of outcome with general anesthesia? We need good science. We need controlled studies. And so it's not always that simple, impressive though that it was. I'll be talking about the role of regional techniques. It's like speaking to the converted. You already know regional techniques have many benefits, but I will also be a little provocative. For example, I want to ask a question. How many of you are using epidural technique routinely for postoperative analgesia? Please raise your hands. Well, just about everybody is using. So I'm here to say that it's time to reconsider the use of epidural technique for postoperative analgesia. So I'm being a little provocative. I think regional techniques are the best, but not necessarily epidural. One of my messages is to go peripheral, go as peripheral as possible. And I'll also be talking about some new developments, something called, for example, the LIA technique, L-I-A, LIA technique, local infiltration analgesia technique. In Sweden, where I work, 75% of all total knee replacements are done by LIA technique. And epidural is certainly not a part of that. It is using, I'll get back to that in a little while. So there are new techniques coming. And so to get started, this is my hospital, Örebro. Sweden is a small country with only about 9 million people. Örebro is in the central part of Sweden. It doesn't look like this for about 6 months in a year when it is all covered by snow. So when you come in summertime, you might get to see something like that. So yes, there are many benefits of regional techniques, whether you use it alone or in combination with general anesthesia. It is definitely the technique of choice in obstetrics. For example, in Sweden, I think over 95% of all cesarean sections are in under regional anesthesia. Women want to be awake to participate in the delivery process, and so it would be impossible without regional techniques. Also for labor analgesia, extremely important. It is the best analgesia technique for dynamic pain relief. The surgeons want the patient to be up and about, rehabilitated, to be mobile as soon as possible after surgery. And for this kind of dynamic movement-related pain relief, opioids just don't do the job. I'll come back to the issue of epidural technique, and we've heard about perineural catheter techniques, but there's no question that regional techniques are superior to the alternatives that we have, opioids, opioid PCA, etc. So I don't think this guy is very nervous, should I use general anesthesia or regional anesthesia? I think there is good evidence that in many situations, the use of regional techniques, perioperative regional techniques, have several benefits. One should also say that general anesthesia also has made advances, LMA, quick-acting drugs, etc. Also, we know that the risks have gone down, and general anesthesia also is generally very safe, but there are many more benefits with regional techniques. I'm not going to go into all this, just to tell you that there's a huge variety of techniques that are at our disposal. Some benefits, for example, the issue of nausea, vomiting, and I would also like to mention at the outset, I will try to stick to evidence-based methods, to meta-analysis, and stay away as far as possible from individual studies, because individual studies, it's like reading the Bible. You can get what you're looking for. So whether you are pro or con anything, you will find individual studies. But I will stick to meta-analysis, systematic reviews, etc. So here's one review by one of the gurus in PONV, nausea, vomiting, AFL, who is telling us, based on all the literature, that volatile agents are emetogenic. Every third to fourth patient has nausea, vomiting. You want to reduce that, use propofol. You want to reduce further, use total intravenous anesthesia. But if you want the best results, you want to use regional techniques. Another issue, this is about the issue of cognitive decline in the elderly patients. Again, a systematic review, not going into the details, but what it says here is that, and it's not very clear, this is multifactorial, and so it depends. So generally speaking, if you use general anesthesia or regional anesthesia, it doesn't really matter as far as cognitive decline is concerned. However, there is some evidence that in the early postoperative period, the first week or the first 2 weeks, you are better off if you're using regional techniques, particularly in the elderly patients, and more importantly, if you avoid the use of opioids. Going to the area of ambulatory surgery, I know it is not used that much in this country, but this is something which is coming definitely also to India. It is increasing all the time. I'll get back to that in a moment. But one of the main symptoms, this is the kind of symptoms patients have when they go home, and these are the symptoms: fatigue, dizziness, etc. But every other patient seems to have pain at home, and this is expected to increase as we do more and more surgical procedures, more complex surgical procedures on daycare basis. And so in these scenarios, and I know there's a lecture in the program, regional techniques have a role. This is Bill Clinton when he was the president of USA, and he had some knee surgery, and he was given regional anesthesia because he has to be in command with the hotline, etc., as you know, and so they decide to have regional techniques. And I say, if regional technique is good for Bill Clinton, then it's good for our patients too. There are certain other advantages of using regional techniques in ambulatory surgery. These are not fantastic studies, and this is not any meta-analysis, but some studies telling us that you can reduce the length of hospital stay, unplanned admissions, better patient satisfaction, better sleep pattern, better post-operative functional level, activities of daily living, etc. Again, not great studies, but just showing a trend that there may be some benefits, and this needs to be studied further. So coming back to this issue of epidural, which you all said that you're all using, and we have all been using epidural for years. It is, in fact, has been the gold standard and still considered to be the gold standard for many, the Rolls-Royce of pain management. And there are many benefits. Excellent analgesia, there is nothing better than epidural. There is good literature showing that post-operative ileus in the post-operative period, the duration is much shorter, maybe 24 to 36 hours shorter if you use epidural. Also, reduction of pulmonary complications. This is a meta-analysis in '98, and reduction of risk of myocardial infarction. This is another meta-analysis of 2001, and perhaps reduction of persistent post-operative pain. I will talk about that tomorrow. And also some evidence of reduced risk of cancer recurrence. Major benefits. That is fine. However, if you look at new studies, large studies, then we will have to reconsider. These are old studies, and there was a Cotra study which in fact also showed a reduction in mortality and reduction of major morbidity. But there were several flaws in that study, and new literature tells us that the role of epidural in reducing morbidity is not as impressive as we have believed in the past. Times change. The type of surgery we perform today is not what it was 10, 15 years ago. There's much more minimal invasive surgery. We are using this new generation of anticoagulants, and we are also we also have other choices in regional anesthesia, which I will come back to in a little while. So yes, epidural is wonderful. All those benefits, like this guy who can play any instrument, we could do anything. We can have analgesia right from here to the toes. Wonderful, but again, I think it's time to reconsider. Epidural is also wonderful in the labor scenario where you want the woman to be able to push and to be able to help with the delivery. And now I would like to ask you something, because a good epidural is the one, this is what the surgeons want, the so-called walking epidural. Now please raise your hands when you're using your epidural, not for labor, because this can be done for labor as well as for post-operative analgesia. So please raise your hands, those of you who use your epidural, and then you're using the walking epidural, because this is what the surgeons want. This is what we want out of epidural, to have the patient up and about and mobile. So mobile epidurals, if you like, please raise your hands. Not very many, and in my opinion, that is where one of the problem lies. Having a patient pain-free while lying in bed is no big deal. Anybody can do it. It is the challenge of providing good analgesia when the patient is up, when he's moving, and needs to be rehabilitated. And that is one of the problems we have, I think, with epidural technique. So again, a meta-analysis here, 3,800 clinical trials, 18 meta-analysis, 10 systematic reviews, 10 additional randomized studies, huge amount of material. What does it say? Finally, there is insufficient evidence to confirm or deny the ability of analgesic techniques in general. Not only epidural, there is no real evidence. We would like to believe when we perform an epidural, put in all that effort, that there will be major effects. the sad story is analgesia itself is not always leading to reduced morbidity or mortality, not always. And there we have a bit of a problem. I think we have these fast-track, enhanced recovery protocols, and patients are going home much earlier today than they used to do some years ago. But that is because of protocolized systems, special protocols, not only due to analgesia. Analgesia is one component of a whole multimodal rehabilitation protocol. So what about epidural for colorectal surgery? This is a meta-analysis showing, again, as I said earlier, yes, there is a shorter duration of ileus by 1.6 days. Yes, good analgesia, but this is associated with pruritus, urinary retention, hypotension, and it does not affect hospital stay. So despite improved analgesia and decrease in ileus, epidural analgesia has adverse effect and does not help with the hospitalization time. Here, abdominal and thoracic surgery, looking at pulmonary complications, and it says again that there is a general trend that the pulmonary complications after surgery are going down, no matter what you do, whether you use epidural or you don't use epidural. What has happened during the last 30 years, it says the incidence with epidural, the risk of pulmonary complications is 8%. But if you're using opioids, the risk has gone down gradually and now is about 12%. So no major benefit of epidural. So it says the conclusion, epidural analgesia protects against pneumonia following abdominal or thoracic surgery, although this beneficial effect has lessened over the last 35 years because of decrease in baseline risk. Here is an editorial not so long ago, what says that epidural first do no harm. There is lack of good evidence about complication rate of epidurals. A lot of studies, this is so rare that there are not many good studies. But it seems that the risk of complications, there's a Swedish study showing for over a 10-year period, over 500,000 epidurals and about 1 million plus spinals, showing that the risk of severe neurological complications is greater than believed in the past, although relatively rare. Then there is something from UK, more prospectively, that it is not as bad as the Swedish group says, but still something like 3 to 6 people die every year in UK, and there are many, many severe neurological complications. I would like to say the risk is extremely rare, or rather rare, but it is a disaster when it happens, even if it happens once in 10 years. So it also says here, do you have another pointer? It says here up to 50% epidurals fail or give inadequate analgesia. Thank you. Up to 50% epidurals fail. I don't think any one of you will agree. But herein lies another thing, and I'm going to ask you another question. I don't think any one of you will say 50% of my epidurals fail. No, but a good epidural is one, because when you put in an epidural, it is there for 2 or 3 days. And I want you to raise your hands, those of you who can tell me what is your success rate or failure rate. Do you have audits? Day 1, day 2, day 3. Do you know how successful your epidural is on day 3? Please raise your hands. The numbers, do you have audits? Please raise your hands. I do not see a single hand up, and everybody is using epidurals. So therein lies the major problem. We perform epidurals, we are convinced they are the greatest thing on earth, and we have no idea whether they are successful or not. We do believe they are the best because we did it. And I'm provoking you, I'm aware of that. So, again, putting an epidural in is not the problem. It is determining what we do with it after it is cited that the problems start. And this editorial says, there is significant lack of evidence supporting the use of epidural, and we question the routine use of this analgesia for abdominal surgery. What about thoracic surgery? This is a meta-analysis comparing epidural with paravertebral and finding that paravertebral is as good as epidural with less risks of urinary retention and the other problems that we have. Here is the prospect group that was referred to. I'm part of that group. This is the procedure-specific postoperative pain management. And again, looking at all the literature for thoracotomy and saying that, yes, epidural is good, but paravertebral is also good. And we all know that it is. Paravertebral is less invasive and less likely to cause problems. So paravertebral is a good alternative to thoracic epidural. What about epidural and major knee surgery? This, the literature tells us, and I'm not going into the details again, we believe that there is now sufficient evidence that lumbar epidural analgesia should not be used routinely, and peripheral nerve block is appropriate for this kind of surgery. Here again, the prospect group, I would like to recommend this website for procedure. The concept is that we treat all postoperative pain as one size fits all. You all know that's a big difference between thoracotomy and hysterectomy or hip surgery. And so it has to be procedure-specific pain management, group of surgeons, anesthesiologists working together to give recommendations, and not recommended. Not only they say what the literature is, but also look at the clinical practice and say what is not recommended. And epidural is not recommended for knee surgery or for hip surgery. And this is hip surgery, and again, what is recommended and what is not recommended, epidural is not recommended. Thank you. I realize that there is a pro-con session here later on this topic. It'll be interesting to follow that. A femoral block, for example, again a meta-analysis showing that, and this is again somewhat controversial, it even goes to the extent of saying that single shot femoral block is excellent and you don't even need a catheter technique. I'm sure that many will not agree with that, but this is what the literature is saying. Also, we're talking about alternatives to epidural. So just to conclude about the epidural, I think the reason epidural is going down is no major benefits. Yes, you do have benefits with epidural if it is thoracic only, and if you use only local anesthetic, not opioids. And most of the clinicians use a combination. So if you use only local anesthetic, only thoracic, also for abdominal surgery, then you might have some benefits in high-risk patients undergoing major surgery like aortic surgery or major abdominal surgery. So that's a special group. But otherwise, it's going down because of risks, because of no major benefits. So alternatives, peripheral nerve blocks, of course, that is why you're here with all the, I'm not going to any details about the techniques and your workshops, that's fine, but peripheral blocks are excellent, and this meta-analysis showing that even if you have a bad peripheral block, it's still better than your IV opioid analgesia. So a little bit about the LIA technique that I mentioned. This is only for hip surgery and only for major knee surgery. This was introduced by an anesthesiologist and a surgeon in Sydney, Australia, some 10 plus years ago, and has become very popular in Scandinavian countries, in UK, Australia, and I also heard from Sugandha that they are using it in Canada too, in some places, and using a huge amount of local anesthetic, much more than is recommended, 0.2% ropivacaine combined with the non-steroidal, I forget the name now, and adrenaline. So this combination, this cocktail of 3 drugs, a non-steroidal drug, ropivacaine, and adrenaline, huge amounts, periarticular use, and then leaving an intra-articular catheter in place, using it in the evening if necessary, or perhaps the next day, and then the catheter is removed and the patient is sent home. About 75% of the patients are sent home the day after surgery, after total knee arthroplasty. This is amazing if you look at what it was. The hospitalization time was about 10 days or more only recently, and still so in many institutions. In Sweden, it's not like 2 days, it's more like 3 or 4 days, but still a major advance compared to what it was earlier. So this technique has really been, has taken over as the technique of choice, and we have a register, and in Sweden, 75% of all total knee arthroplasty surgery is done by this LIA technique. I'm not going into details because this is a lecture in itself, but this is something which has really come about, and so epidural for hip and knee, nobody thinks about it anymore in our part of the world. Here, for example, this from Norway, looking at this LIA, high volume local infiltration technique, comparing with epidural, and again, with the LIA technique, this is ketorolac, was the drug I was talking about. LIA technique, better pain scores, and this is comparison with epidural. Better, less morphine, superior knee function, faster mobilization, and earlier discharge, 3.5 days versus 5.5 days in the epidural group. So very impressive. But also, I think when we are talking about multimodal analgesia, when we are talking about this LIA technique, when we are talking about enhanced recovery, multimodal rehabilitation protocols, I have a problem with definition because your LIA is not my LIA, your multimodal analgesia is not my multimodal analgesia. People are mixing, and many times we don't have a good definition. And I wrote an editorial about that because many times we are comparing oranges and apples, and this is a nomenclature issue. We need to know what we mean by multimodal. Everybody says it's a mantra. I use multimodal, but you talk to your colleague, his multimodal is different from your multimodal, and we need some consensus. A little bit about transabdominous plain block. Again, this is early days, but this could also be a good alternative to epidural, and it has been used for these kind of surgeries, hysterectomy, C-section, appendix, cholecystectomy, etc. So it seems to be promising, early days, but as I say, we all want to use regional techniques, but not necessarily epidural. A little bit about ambulatory surgery. This is the trend during the last 20 plus years in the United States. Here, something like 70% of all surgery in USA, or maybe 80%, is ambulatory surgery. In Sweden, 50%. In India, much lower, but guaranteed to increase all over the world as we have more and more economic pressures, and also with advances in surgical techniques, anesthesia techniques, and in this area, as I said earlier, regional techniques have a major role to play. Many years ago, we introduced this concept of having regional techniques at home. These are patients, as I said earlier, I showed a slide that huge numbers have pain at home, and so we introduced this concept with these elastomeric balloon pumps filled with local anesthetic, just a clamp there, and a catheter put in different places. It could be perineural in the wound or many other places, periosteal, etc. When patient is at home, opens the clamp, local anesthetic goes in, and by closing the clamp after a few minutes, by opening and closing the clamp, so it becomes patient-controlled regional analgesia at home. This was a rather primitive system, and of course there's a risk if the patient fails to close the clamp, everything goes in. So nowadays you have more advanced clamps, but when we started, this cost US dollars 15. Nowadays it's 10, 20 times more. I don't really know why. It is a little bit safer, but I still don't know why they should be so expensive. But anyway, this technique of treating pain at home has taken off, at least in the United States and in some other countries. And also, this is a review article about continuous peripheral techniques at home, showing that it works, but that we need further studies. And also, this very simple technique of putting catheters in the wound. It is so simple that we are joking and saying even the surgeons can do that. And in fact, it is the surgeons who do that. And this is a meta-analysis of 40 studies showing that good pain scores, less nausea, vomiting, sometimes less hospitalization, and no real adverse effects. So it's a very simple, safe techniques, and I don't think we should underestimate the importance of such simple techniques. Don't have the time to go into details, but it is not only for minor surgery that we are talking about. We are talking about abdominal surgery, vascular surgery, cardiothoracic surgery, gynecological surgery, orthopedic surgery, etc. And this is from the Australian, New Zealand guidelines. This also I recommend you to read. Here's your address. Good document from Australian, New Zealand Society of Anesthesiologists. And for wound catheters, this is what they're saying, that it works, and both at rest and activity, good analgesia, less opioid consumption, and there's very little risk of problems, and this is strengthened evidence, level 1 evidence. So it is evidence-based literature, and also many different areas of the body where you can use it. However, I would like to say that there are situations where it does not work, and this is still early days, and we need further studies. I'm sorry about this very busy slide, and also I noticed last night looking at this that there are some errors about references. Don't need to go into that, but generally speaking, comparing wound infusions with neuraxial techniques, many studies showing that it is better, some showing that it is not, for example, for prostatectomy, and also comparing with peripheral nerve blocks. 3 studies, one saying better, one saying equally effective, one saying femoral is better. So it's kind of unclear at this stage. For shoulder surgery, interscalene is definitely better than wound catheters. And also for spine surgery, wound catheters may not be the best. So we need to know it's not like working for everything, but it is simple and safe. And there are many questions. Where should we put the catheter? How deep should the catheter be? Should we use adjuvants? And there are many questions. So it's relatively new technique, but it should be considered when you don't have the possibility of other advanced blocks, or even as part of a multimodal analgesic technique. So the question is, you are all using epidural and say, what is he talking about? Don't we have any indications anymore for epidural? Yes, I think we have indications. It could be extensive surgery involving large areas of the body. These places, it takes time to introduce new techniques. So yes, you want, if you're not doing paravertebral block, you can't start doing it tomorrow when you go home. So you should still use your epidural, but while you're training your junior colleagues or yourself, then during that transition period, epidural still is the best technique. Also for high-risk patients undergoing major surgery, as I said, for labor analgesia, there is no alternative. It is still the gold standard, and there might be new indications in the future, anti-cancer effects, and also perhaps risk of surgical site infections. Here are some papers telling us that there is reduced risk of cancer if you use epidural, but it is not only for epidural, it is also for other regional techniques, and it is still controversial. There are studies showing that you will have improved oncological outcome with regional anesthesia, and there are in fact more studies showing that it has no benefit. So it's a very exciting area if it were to be true that regional techniques reduce the risk of cancer recurrence, but it is still very early to say if it is so. Here is a study showing that if you use epidural technique for hip or knee surgery, then you can reduce the risk of surgical site infections, but this is only one study. So we need more studies. I would also like to say that outcome, because that is my topic, to talk of outcome. So it's not only regional anesthesia, outcome is so many more things, and so we have to look at the role of others, the surgeons too. You need to have a good surgeon, a high volume surgeon in a high volume hospital. Good evidence to show that. Those who are doing it all the time have good outcome. There is no benefit of operative drains, and this we have shown also in the prospect group for hip and knee surgery. How many of your surgeons are using drains for hip surgery, knee surgery? Please raise your hands. Wow, this would not be acceptable for many, many institutions that I know. Surgical drains, and please go to this website I said, www.postoppain.org. You can see literature showing that drains increase pain, drains increase the risk of infection, drains do not have any benefit. Now, if you go tell your surgeon, I think you should stop putting the drain, you know what he will tell you. But that is up to you how to convince your surgeon, but the evidence says no drains. Okay, no benefit of perioperative nasogastric sectioning, no benefit of mechanical bowel preparation for colon resection, no benefit of routine parenteral or enteral feeding. Again, provocative statements, all evidence-based. So this affects outcome. So you can put as good a block as you will. If the surgeon is also not doing the things that they are supposed to do, it will not improve your outcome. So outcome is multifactorial. We have talked about the regional techniques, but there are patient issues, smoking, alcohol consumption, how well prepared is the patient, role of surgeon, ward routines, physiotherapy routines. I'm sure you're familiar with this because this is an Indian children's story. I remember as a child growing up about this story, telling us about these 5 blindfolded men who are to go and identify what the object is. And this guy is looking here at this hard, sharp object and says, "Chaku hai." This is chaku, this is a knife. This guy looks at this area and it's moving, and he says, "This is a python, this is a snake, samp." And this is, guy's putting his arms around the leg here and says, "This is a tree, a pear, tree." This one is going and says, "This is a rope," and this one is going out there and saying, "This is a wall." So they're all right and they're all wrong, and we all have to work together because the surgeon is looking at his area, the anesthesiologist, the nurse, etc. And so we need a complete picture if we are going to improve the outcome. So again, walking epidurals. This is old picture. We've been doing this for close to 20 years, more than 15 years for the parturian. She's going to have a baby soon. She has an epidural PCA, and she is walking in the corridor. This guy underwent major abdominal surgery. The day before, they seem to be smiling and they are walking. This is what the surgeon wants, and that is what epidural can do, which no other technique can do. But if you are not using like that and they're just lying in bed, why use an epidural? And one of my last, I just have very few slides. I can see I have a little time. Okay, so this is the point I was making about audits. We will go every year to all the different surgical sections. Here, section of general surgery, all the surgeons sitting here, I'm sitting there. This is our pain nurse, and giving the surgeons the information from the year before. We had so many epidurals, so many perineural techniques, so many catheters, whatever. So many were successful, so many were not. There will never be 100% success. It is from our failures that we learn to improve. So we will give all that information, and that's why we know how good our epidurals are. And that's why in my institution, epidurals have slowly gone down over the years, because we were not so convinced that they were the best technique for all kinds of surgery. So my point is, you need to have your own audits. What the literature says is fine, but what is your own practice? What is your own success rate? And very few people, as we saw here, are doing that, and I'm afraid unless you do your audits, you will go on believing you are the best. You will have to see your own numbers to be able to convince your surgical colleagues. I don't have the time. This is again a lecture in itself, acute pain services. We have a pain service which is different to the USA model. This is a nurse-based, a specialist nurse-based anesthesiologist supervised acute pain service. And provocatively I say, now I'm almost retired, but I was responsible for our pain services, and when I was there I used to say, I am the director of pain services and I never see a single patient. And that is true, because I said it is not my job as anesthesiologist to get up at 2 o'clock in the morning to turn down a PC. The nurse can do the job. And I have heard from many saying, oh, our nurses cannot do that. Well, they definitely can if you teach and train that. Nurses can, within prescribed limits, they can do what they are expected to do if you teach them. Our nurses will inject drugs in epidural catheters. They will turn down the PCA pump. They will do some other things within limits. And if they exceed, if something is above that or something is not right, they will call the anesthesiologist. So we are teaching and training our nurses on the ward. And your pain service will be only as good as your nurses on the ward. So I know this is also very provocative, but it can be done, and I do know from personal experience in this country, I know somebody sitting here who will agree with me, or more than one person, and I've seen it in Delhi and a couple of other places where this kind of thing is being done, where nurses are upgrading the role of ward nurses, teaching by specialist nurses, supervised by anesthesiologists. And this kind of system is well accepted in Scandinavian countries and some other places in Europe. You have to have goals. Our goal is that no patient shall have pain above 3 on the visual score. And so making pain visible, pain is charted, this for every patient. We do 20,000 surgeries a year. So this is ward nurse training that I talked about, and this is the acute pain nurse who is now teaching, bedside teaching the ward nurse about PCA pump. So we have routines. Every patient is getting paracetamol. Every patient is getting wound infiltration. All those 20,000 patients. And then, depending on the type of surgery, we'll get other peripheral blocks or whatever is necessary. These pain management routines are integrated into surgical clinical pathways. Patient information is important, and audits I've already talked about. So very briefly to summarize, some people are very pessimistic, and you heard this half empty and half full. Well, it depends where you are. This guy is saying you're always complaining, you're a pessimist. Well, he can afford to say that. And so my point is, some are pessimists, but I'm very optimistic here about regional techniques. And once again, I want to congratulate AORA, the board of directors, Dr. Bala, for taking this great initiative, and I have very high hopes about this new society that you have. Many methods to treat postoperative pain on a peripheral level, spinal cord level, and also some also on a central level. Talking about regional techniques, my message, as I said, is to stay away from the the central neuraxial blocks, and more on the peripheral techniques. Epidural, I have always said, I think you have to make a decision for every individual patient. Is it really indicated in this particular case? So the choice of epidural should depend on your audits, not on old-fashioned traditions, if you like. So what about the main topic that I have today? There is excellent evidence that the regional techniques are better, provide better analgesia than the alternatives we have. Reduction of opioid adverse effects such as nausea, vomiting. Good evidence that in high-risk patients there is a reduction of pulmonary and cardiac morbidity with epidurals. Reduced length of stay as part of enhanced recovery protocols for colon surgery with epidural, wound catheters, and also for thoracic, total knee and hip surgery with perineural blocks and this LIA technique that I mentioned. These techniques may, as I said, I'll talk about it tomorrow, they may reduce the risk of persistent postoperative pain, there's a question mark here, may reduce risk of cancer recurrence, and may have some short-term benefits for POCD. These are the benefits that we are talking about. So you have this dog here who has three choices. You have your spinal and epidural, you have your peripheral blocks, and you have your wound catheters and periarticular techniques. So they are all regional techniques. They are all helping for different kinds, and so you have to make a choice. My choice is, as much as possible, the wound catheters and peripheral techniques, because they're simplest and safe. And then if they are not working, and also to have good indications for your perineural techniques. I would also finally like to invite you to a meeting here in India, in fact. This is the 8th such international meeting in Cochin, India, and Dr. Bala knows about it, and we'll have more regional techniques, a faculty of international speakers and some Indian speakers, and talking about regional techniques, acute pain, and also chronic pain, if you are interested. This is in November 14 to 17 in Cochin. And I would like to thank you very much for your attention. And once again, I'm very privileged, and I am indeed honored to get this very prestigious award. Thank you very much.